we're all right.
I think we're in good shape. So people are coming over right now. I would like to introduce Stu Campbell. Stu currently works as a Band-Aid advanced practitioner in the NHS and as a lower limb and foot ankle specialist. So I'm going to pretty much turn it over to you and let you take it away. I'm really interested in the presentation.
Thank you. Okay, so what I'll do, I'll share my screen. Let's see. Yeah. Okay, is that okay on your end, Rich?
I can't see it. Did you hit lower left to share screen? Click the screen, then hit share. There we go.
Yeah, it's just showing on my end.
Okay, yep, I got it. It's up.
Yep.
It's awesome. All right, man, take it
Cool.
away, my friend. In a little bit.
Thank you. So thanks a lot, Jeff, for putting a load of pressure on me to rush through my presentation. Thanks for making it all about yourself, first of all. I think the interesting thing about the talks today is, like, I've never met Rob or Jeff before, and the talks are going to flow quite well, which is nice. It's almost like we've rehearsed it, which we haven't done. Ultimately, my initial role as an undergraduate was a podiatrist, and then my skill set has been mixed and varied. So I work as a strength and conditioning coach, a podiatrist, a sports therapist. So I think the balance of what everyone's speaking about now is I sort of fit somewhere in between. And I think it's nice when you've got a collective of people where the ethos is shared, so to speak. So today I want to speak about ankle impingement and how I have tackled this recently in my clinic. It's my first time talking to the States, so I'm apologising in advance for my very broad Mancunian accent. I'm from Manchester in England. It's night time here, but it's not raining for once. So what I want to do, I just want to take you through some of the basics of the pathology itself, hopefully stimulate some debate at the end. More than happy to be fired questions in the round table. And obviously, I just want to talk about how I've gone about treating it. Now, the reason I picked this one is because it's a pathology that it gets missed quite a lot. The statistics in the UK are quite high for ankle impingement being misdiagnosed or underdiagnosed. But what we do know, we know that ankle pathology as a whole is very, very common. You'll all see your ankle sprains, your Achilles injuries, and I imagine if anyone's got even a year of experience, they'll have seen a decent amount of ankle injuries popping through into their clinics. Over 2 million in the States and the US alone, so it's very, very common, and it is something that we need to unpick a little bit. And it was interesting when we were talking about Jeff was talking about technology versus experience. It's the experience side of things mixed with the technology where you can start to unpick this and unpick it successfully, hopefully. There's strong evidence with the vast majority of ankle pathology that you've got a very good chance of re-injury within a 12-month period. And I think just ATFL injuries themselves, the ligament itself is like tissue paper, and that's essentially you've got a 47% chance of re-injury in that. I'm sort of aware that I might be speaking a bit quick now. Rich has just had a knock at the Brits for talking quick, so I'm trying not to. Ankle pathology or ankle impingement is quite complex. Now, it's complex in its variety, but it's held together by a couple of common denominators within that injury. Essentially, you've got a wide range of sort of anterior and posterior onsets. The main thing is, to break it down in its sort of simplistic form, is you've got the structure. If you're looking at the front of the ankle, you've got the mortise, which sort of looks like that, made up of your ankle joint. And the structures within there become clogged up or littered with various products such as swelling, cartilage proliferation, loose bodies, scar tissue. You can start to develop osteophytic lipping and other sort of bone formation as well. The impingement itself, it covers quite a lot. Now, there's a really good article. In fact, I emailed Zachary Berman yesterday, actually. The article is linked in the references at the end of this presentation. It's a brilliant article, very comprehensive on ankle impingement. I'd strongly recommend you read it if you're interested. It's very, very thorough, essentially. Now, the underlying diagnosis of ankle impingement is very, in my opinion, it's more common than you think. I think there's quite a lot that are slipping through the system and we're missing that diagnosis. And I think it's a very good presentation when you get an athlete or an individual who comes in, I've got ankle pain, and you do all your checks and you check your strength and everything else, and you think, well, actually, that's quite good. Like, maybe they just need to rest. You know, the strength's good, they've had a good level of physio, but the patient themselves are still in pain. So that's where we need to start thinking differentially. Now, the history taking side of things is, whenever I've taught students in the past, this is the one that I've sort of really hammered home with people. I mean, I'll write a good portion of information when it comes to history, and I'll pick up on things that left, right, and centre that they're talking about. And you'll always pick up, well, 9 times out of 10 with an ankle pathology, you'll have a history of inversion injuries or a history of inversion plantar flexion injuries, things like ballet and things like that. But essentially, once you start to nitpick through the history, I like what I think it's sort of on the level of what Jeff was saying, where you're trying to sort of think more widespread. So, what's wrong with you? It's my ankle, right? Okay, so let's talk about what else have you had, because we know it's all connected. Have you gone over on this ankle before? Have you had lower back pain? Have you had tight IT band? Is there a collection of symptoms that have created an antalgic gait, or have you just damaged your ankle and developed an antalgic gait afterwards? Because that's the very key pieces of information, those. And important ones when we want to start talking about, first of all, diagnosing, and then where we go from there. Now, these particular people will have been unresponsive to physiotherapy or any other sort of remedial therapy they might have had. And they're looking, the sort of the last ditch attempt is, you know, they're in your clinic. The differential diagnosis of impingement, essentially, you've got quite a few. Sinus tarsi syndrome, cuboid syndrome, perineals, tendinopathy, tenosynovitis, fractures, osteoarthritis, syndesmosis injuries. There's a very common one as well where you can get talonavicular synovitis when you're testing, which I'll explain in a little while. But essentially, there's a load of traffic going on around that site, and you've got to start sifting through all the rubbish to try and determine an accurate diagnosis. And often you will opt for imaging to an extent on this once you've got a diagnosis confirmed in your head. But you do need to be careful about the differentials. And obviously you all know that, you're all very experienced people. The inversion side of things is, to me, the common denominator. Now, I've seen patients come in to clinic when I've been reviewing them on behalf of someone else. I don't know what it's like in the States, but occasionally, sometimes in this country, we can give insoles or orthotics out. And I don't see the logic in why they've given something out. One of the most infuriating things for me is if I've got a patient with a high gear foot posture where they laterally load, so they're inverted. Some people call it supinate, but essentially it can be on the outside of the foot, and then you give that person a big arch profile. That's illogical to me, because all you're doing is you're pushing the foot that's already inverted into further eversion and throwing them out more, and then you'll charge them, I don't know, $500 for the privilege. So essentially, they might have had insoles, they might have had physio, and it's our jobs to nitpick. Well, what actually have you done? You know, have you been sat on a bed with a hot pack on you while the physio treats someone else? Have you been given the wrong insoles? So we need to sift through the rubbish again. Now, the clinical presentation is limited range of movement in the ankle, but it's not always the case. Like, sometimes you can still be competitive, you can still be playing sport, just not to your full capacity. Swelling can be intermittent. It's typically localized to the lateral aspects, but it's, it can come and go. It doesn't necessarily mean it's there all the time. The patient can say, where have you got pain? And they'll say, well, it's here, and it goes through. Or they'll say it's here and here. So they'll pick both sides of the ankle. The sort of the real horrible patients when they say, I've got pain here, 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 and here, and it goes up your leg. And then you're thinking, you've got to, it's one of them where you've got to try and go through the layers again, haven't you? There is instability. Usually your structural ligaments are intact, but there is instability, and it's usually due to a fear of loading. And that's where that sort of antalgic gait can come in, which Jeff was mentioning earlier on, actually. Again, we've not met before, so it's not pre-planned. But when it comes to the dysfunctional side of things, is there an instability there because the ankle's unstable, or is there an instability there because it's the cause and effect sort of debate? If you've got pain in there and you don't know why, as an individual, you don't know what's wrong with your ankle. I've done all the physiotherapy, my ankle's strong, my strength measurements are all normal. You start to develop there will be a psychological impact on you, and you will start offloading that ankle. You'll start loading the opposite foot, or you'll start compensating through your gait. You'll start getting tight glute med, tight calf muscles, and this, that, and the other, and you'll get this knock-on effect. Now, ankle impingement itself, when it comes down to its complexity, it's split into 5 subcategories typically. So you've got anterior, anterior medial, anterior lateral, posterior medial, and posterior. Now, I think if you can accurately diagnose anterior lateral, for example, or posterior medial with your clinical testing, then fair play to you. I think you're doing well. I think from our point of view, once you get these patients in, the shared decision making needs to kick in. Where do we need to do further imaging, and do we need to get a surgical opinion or a consultant opinion on this particular case? You can, when you see enough of these, you can start to determine whereabouts this pathology is. But I think what I would encourage is, if you've got one of these patients in where they're not responding to treatment and they're on your plinth, they're on your table, I'd be thinking, yes, I'm thinking this is impingement, and I'd be thinking getting an MRI scan or whatever imaging you're going to do, which we'll come on to. Anterior medial. Now, essentially, I'm just going to whip through these because I don't want to start chewing your heads off about pathology. Most of you probably know a great deal about it. But essentially, anterior medial is damage sustained to the sort of anterior tibial talar ligament. Now, this sort of pathogenesis or etiology, it's very common in all of them, where there's an injury to a structure, normally through movement. So it's not necessarily through trauma, though trauma can have a knock-on effect. So if someone's been playing football or soccer and there's been a tackle, that proliferation of scar tissue within the mortise could create an impingement. If you've gone over on your ankle doing something like, I don't know, basketball, or you've landed on someone's foot, or you've just rolled your ankle, or athletics or something like that, then the ligament essentially becomes damaged. Scar tissue forms, the thickened ligament becomes even more unelastic than it was beforehand, and then you can start to develop this inflammatory impingement sort of onset around that site. Now, repetitive microtrauma can also lead to this. If you take, I'd say probably the best example is someone like a ballet dancer in the right circumstances, where you're going up onto your foot into sort of, into certain movements. You can start to develop a repetitive trauma over a long period of time, which can then create an issue. So you might be getting patients coming in their late 30s, early 40s, presenting with this. And the damage may have been, it might have started a long time ago. That's why the history taking is so important. But the difference between sort of anterior medial, anterior lateral, anterior is more structural in terms of bone formation. Now, it was argued in the literature that if you look where the arrow is pointing to the little red lesion on the tip of the tibia, it's almost argued that it's a bit like a hand deformity, similar to that in your hip when you get pincer or cam deformity in your hip. If you look at that foot now, if I was to passively dorsiflex the forefoot into the tibia, you're going to get pain because you're going to get that pinch. So the anterior ankle impingement tends to be a bit more structural, where you might be getting this pincer sort of deformity. Now, when you're testing for this one, your differential diagnosis is typically an osteochondral lesion, or even to a lesser extent, talonavicular synovitis, because it's anatomically it's in the same region. But it was initially attributed to osteophyte formation and lipping, but like I say, there has been sort of some key features in the literature where they've discussed cam deformities. And obviously in this respect, you'd do a lateral sort of weight-bearing x-ray if you were suspecting that. But I imagine if you were going to refer to a consultant, I don't know how it works in the States, but if you were going to refer to a consultant, they'd do a battery of x-rays and MRIs anyway, just to pick up on everything that's going on, even a CT scan to an extent. Anterior lateral, again, this one, scar tissue, reduced range of movement, effusion, starts to build up in that very small space, and that sort of structure becomes clogged up and starts to reduce in range. The most common ligament in this is the AITFL, so it's it's right there, and it starts to develop scar tissue, and then beneath, because you've got gravity working against you, you'll get scar tissue pulling underneath, which then sits into that mortise, which then gives you that nip when you start to move. And you might have someone who's just rolled their ankle that many times and they just can't be bothered going seeing someone. So they've just not sought physiotherapy out or anything like that, and they've just got on with it, basically. So this is sort of the scar tissue sort of impingement that's being created. Posterior is slightly different. So posterior impingement tends to be more associated with a prominent sort of stylus process or an osteogonum, where you've got, again, similar to anterior, you've got anterior and posterior, so that it's almost like, it's not a cam, but it's almost like a cam, because it's a bony impingement that's creating the issue. Now, I think you could, if you x-rayed people, you'd probably find quite a few different bony anomalies, and if that's their anatomical norm, then fine. That's just the way you're made, and if that's you, don't worry about it. It's like when people say they've got flat feet or they do this, that, and the other. Who cares? Like if you're not having any problems, that's just you, and that's absolutely fine. Usain Bolt had pretty flat feet and he did all right for himself. But essentially, with the stylus process, if that's symptomatic, you would be looking at a consultant opinion most likely. Similar to sort of the other issues, you've got a bone that's actually probably the center piece of the diagnosis, where around it you've got this formation of scar tissue and swelling and lack of range of movement and this, that, and the other. So again, you'd be sort of repetitively overloading that, and that's the same for all the subcategories. You're just sort of looking at whether there's an initial causative factor like a bony prominence, or whether there's an accumulative onset of pathology. I hope that makes sense. The posterior medial is more rare, to be honest with you, where the patient will complain of this, and it's usually a case of it's around the joint capsule more, and it typically is the sort of synovial thickening and synovitis. Now, to be perfectly honest with you, I think that once you've diagnosed the patient, if you're suspecting pain, because the patient will tell you pretty much where the pain is, it's posterior medial. Once you've worked out your differential diagnosis of the anatomy around that site, you'd probably be looking at getting an MRI scan at this stage, and maybe getting a consultant opinion in where they'd start to look at the capsule and the synovial thickening and the retinaculum and all the other bits and bobs that go on around there. But that, to be honest with you, that would be a great diagnosis if you picked it up clinically, but most likely dealt with at sort of consultant level, in a sort of shared decision approach. And like I say, they are on the rare side, those ones, the posterior medials. So the clinical tests, What I've done is, because obviously I can't demonstrate them, so I'm sat in my kitchen at night and no one wanted to come around and spend any time with me. I've put a slide on here with a link to a very good channel on YouTube called Physio Tutors. I've never met them, but their clinical testing demonstrations are very good. So the clinical test that I use, the video links on the presentation. So I'm assuming Mitch will probably send the presentations out to you guys so you'll have access to them. But for the clinical assessment on anterior ankle impingement, it's a forced dorsiflexion test essentially. It's very, very simple. You basically just cradle and really sort of put your body weight through and forcefully dorsiflex the foot. You'll tend to get pain quite commonly through that site. Now they can start to, if they're okay, they'll moan about their Achilles tendon or the calf and say, well, it's tight going down the back. And that's where you're sort of really trying to sort of look at whether this is, it is an impingement or is there something else going on. It can create a pinch because if you think about that sort of cam deformity, that'll be quite sensitive. So you'll have positive once you've repeated it once or twice. And they'll be able to explain movements as well, like walking down the stairs, for example, something where you've got increased dorsiflexion, things like that will come up. But maximum dorsiflexion test, I know it's difficult to sort of visualize, but please go on the video links and have a look. It is on one of the slides. There it is, it's on that slide. For posterior ankle impingement, when you do the forced dorsiflexion test for anterior, they'll tell you whereabouts the pain is. So you can then start to roughly get an idea of whether it's anterior, lateral, medial. It's the same with the plantar flexion test. Now the heel thrust test, which is explained with quite good sensitivity and specificity, is on there, and it's a demonstration. Now posterior ankle impingement passive plantar flexion test is the main one that I use, and unfortunately I couldn't find a video link for it. But the paper was done by a colleague of mine who's a chap called Professor John Rogers, who's a great sports medicine consultant, one of the best, where essentially you take the foot. What I would do is I'd stabilize the tib and fib, I'd clamp them down, and I'd passively plantar flex the foot. Very sensitive test. And I've noticed people, it's been a very accurate, very useful tool for me. So if you can find, the paper is in the references below, but the John Rogers paper is a very good one to read, if you can get a chance to look at it. So, treatment options for ankle impingement. What we know is, we've now switched our brains on and we're thinking, right, okay, well, what is it? It's definitely not osteoarthritis, because that's what everyone says in this country. You've got osteoarthritis. And then 4 years later, you end up getting diagnosed with something that you could have dealt with. We have a big thing where we call shared decision making. My job is to give you the options, and then you can make an educated decision on what you want to do next. So, arthroscopy, keyhole surgery, very good outcomes with this sort of pathology, depending on the surgeon. If you know someone good, recommend them. Steroid injections, I've seen good results with the steroid injections. Obviously, you're looking at more of a scar tissue proliferation sort of setting where you can pop something in there and settle down the effusion, as opposed to sort of a bony prominence. However, the bony prominence could have been exacerbated by something. So in actual fact, a steroid injection is not a bad way to go. A very good surgeon that I work with who deals with a lot of high-profile athletes, foot and ankle orthopedic surgeon, he will always opt for a steroid injection most of the time in the first instance. Physiotherapy, obviously, it's the way to go in terms of trying to get everything nice and strong. Orthotic prescription is the big one, is the big sort of debate. Like I say, I spend a lot of my time correcting other people's work. As long as you're making a decision on what you're giving them, as long as it's based on functional outcome measures from your clinical assessment, and as long as it makes sense, orthotics are a very good way to go with this particular pathology. Whether you use them short-term or long-term or just for sport, they are a very integral part of this. Rest from activity or stopping activity altogether, it's not something we like to tell people, and it's not something I like to do. I like to keep people as busy as possible. Strapping and bracing, so bracing the ankles in certain respects. in terms of inversion postures, incidentally, the Andy Murray, tennis player, in case you've never heard of him, but the Andy Murray ankle brace is one of the best I've seen. It's about £45. I'm not sure what that is, probably like $60, $70 in your country, but it's a brilliant ankle brace for inversion pathology. Now, what are we missing in terms of how is this applicable to Digisole and to this whole sort of side of things that we're trying to look at? I've brought to your attention an awkward pathology. What do we want to do about it in terms of, most of you probably think, well, I know what he's talking about. Oh, why is he telling me about it? I just want to raise awareness on the subject, essentially, because I know how sort of poorly dealt with it is in this country. I don't know what it's like over there, across the pond. But what are we missing? The gait retraining for me is one of the big ones. Like, this is where the Digisole or the Podo Smart has made such a significant impact in my clinical practice. And I've always been the same as Jeff. I've always been, well, I'll use technology because it ticks a box, but I'll always go off my own eye. I'll always go off my own eyes and what I can see. Now, me and the technology will disagree on occasion, and I'll always go off my own gut instinct. But they provide valuable data that we can interpret. Now, case study is a 41-year-old runner, ex-footballer, so used to play soccer. I used to play soccer back in the day. Very successful chap, very driven, drives an Aston Martin, beautiful car. So he knows, he's very clever, he researches everything, he researched absolutely everything. He asks a million questions per consultation. And the reason I used him is because it's a giant pain in the ass. That's why I wanted to use him in this case today. Now, everything I'd spoke about in terms of the pitfalls, he'd done them without knowing. So, ankle pain for 6 months. Now, it increased during lockdown. Now, I'm going to assume that you guys are familiar with the lockdown. I don't know how locked down you were, but we basically couldn't go to gyms and anywhere really during the pandemic. So, a lot of people started running or walking or doing online HIIT training, which is great for us because loads of people got injured. So our receptionist actually tore a calf doing a class online, the first one. So our numbers went up through the roof, which is great for our profession. But he basically started to get quite significant ankle pain and had it for 6 months. And because he's a stubborn gentleman and very sort of adamant in his ways, he just ran through it. Now, he was diagnosed clinically by me and then sent for an MRI scan with my colleague, funnily enough, it was John Rogers. And essentially the diagnosis was confirmed. Now, John's a brilliant consultant because essentially the last thing he wants to do is surgery on people. So he won't necessarily push you down that route. He'll give you the sort of free rein sort of thing to make your own decisions. So he came back to my clinic. His pain was 8 out of 10 after 1 or 2 miles. He's going to compete at Christmas time no matter what. So it's almost like, right, we need to get on board with him and make him as, I was going to say efficient then, Jeff, but I chose not to. Make him as robust and increase his performance level as much as we can without putting him at risk. He had insoles before, a medial wedge, 3/4 carbon fiber insole, which in this country are very, very popular. Now, I think they're a very good device when they're given in the right circumstances. I think we give them out in this country controversially because of the profit margin, but I'm not going to rant about that. Now, the treatment option, there's no way he was having surgery yet. I think he'll probably end up having it early 2022. I think he'll probably end up going in. Now, he'd ran on this foot for 6 months. So we looked at his footwear. We did change his footwear brand a little bit because I'm not a massive fan of people running in certain trainers. I think certain trainers are very good for the gym and certain trainers are just not good for marathons. And I'm sure a lot of you will agree. So we did change his footwear. Steroid injection he had done with one of my colleagues, and we got some good results to that. One of my other colleagues started doing a boatload of myofascial release. He's got elbows like razor blades, so he got them shoved through all them extremities and started loosening him off. And then we started to unpick some of the muscle imbalances in the kinetic chain. He had atrophy of one of his glute max. He was dominating through his glute med. He was dominating through his hamstrings. So we had to refine the posterior chain. We then carried out the gait retraining program. Now, what I did do was he was very strong on TheraBand and the basic ankle testing that you would do. But we started to go, I opted for more traditional sort of bodybuilding exercises just to put him through the paces. Because for me, it was almost like, well, there's nothing to lose here. We may as well just get you as strong as possible and see where you end up. So he was doing things like Romanian deadlifts, single leg kettlebell deadlifts. He was doing TRX, single leg squats, anything that I could think of that was really challenging for his body, but also would benefit the balance side of things with his ankles. So we threw the kitchen sink at him in that respect. And then the gait retraining was the part that I really wanted to focus on. Now, this is his foot posture. So I used two platforms for analysis. I used the in-shoe digital analysis, which is the PodoSmart, and I use a 2D infrared gait analysis system, which is the one that you can see on the treadmill. And again, like Jeff, not a massive fan of the treadmill because it's not necessarily applicable. However, in this country, 2D infrared gait analysis is a pre-requirement of a lot of insurance companies. And the main reason for that is so we can show the patient what we're doing. And it gives a very good patient report so they can see everything that's going on. Now, if you look at the left image on the left foot at mid-stance, you can see a sort of foot that's very neutral. You've got a nice medial arch profile there, and the foot is shifting more lateral. He had a mild variant. I'll be honest with you, the pictures don't necessarily do it justice, and I took the video out because I was worried that my internet is rubbish. So I took the video out because I didn't want to get a load of complaints. So I've just gone for stills, so I apologise. But he did have a variant posture. He was a lateral loader. He had very flexible functional foot scores. So I knew his forefoot function was flexible. His supination resistance score was low. His Hubschel score was high, which is all good. And he had a high gear foot posture, essentially. Now, he'd been given a medial wedge, which defers back to my initial rant about morons giving insoles out for no particular reason. But essentially, if I'm over on the outside of my foot, that's not going to do me any good. So what do I want to do? I want to change the dynamic of that foot, so to speak. Now, the interesting thing was we did the gait analysis, and I put these images up just so you can try and conceptualize the patient. This is the platform for the run analysis. Now, I wanted to focus mainly on a couple of things. The asymmetry was the one for me in the run analysis. And this is where the gait retraining tool comes in. Obviously, his cadence was a lot slower on the left-hand side, which was his initial analysis. And then post-rehab, about 7 weeks later, the screen on the right is where we were up to. So we've seen an improvement. Now, essentially, it's his left ankle that's sore, and it's the left ankle is the one that's giving him the jip. So it's single support. There's an asymmetry. There's an 8% overload onto the left ankle, and we already know he's an inverter, and we already know that it's the anterior lateral ankle that's injured, essentially. So this is not a good thing to be 8% overloading. Not frustrating thing is, but because this is an older analysis, it was a couple of months ago, I've not got the newtons of pressure going in through the strike pattern. We'll see that if you've got the PodoSmart, where you'll get an arrow pointing down with the pressure. Jeff had one of his slides. What you tend to see when you've got an injury, you'll tend to see an overload in the left column, so 8% in this respect. And then when you shift to the strike pattern, you'll see that there's more newtons of pressure going through the non-symptomatic foot. So you've got this antalgic gait. He's not got the strength to power off that ankle. So he's sort of loading it in a way where it's just detrimental. Now, everything in that side, when it's non-dynamic, it's just going to build tension. Calf's going to tighten up, and then everything's just going to follow from there. And that's where you guys will have a field day, because you've then got loads of things kicking in through the kinetic chain. Now, what we did in this respect, or what I did in this respect, was All of the above. We got steroid injection into the ankle, which gave him some relief. It didn't give him a lot of relief, but it gave him some relief. We got him stuck into the posterior chain. We got stuck into the tight structures. I got him to do active recovery where he was having, soaking his ankles in cold, freezing cold water after a run and whatnot, and doing all the sensible bits and bobs. But the gait retraining was the big one. So what I did was I regulated his cadence. We looked at his watch, his Garmin watch, which was a very, as you can imagine, with someone who drives an Aston Martin, he had a very expensive watch. And it told us quite a lot, actually. Now, his average cadence before the injury was about 170. So what I used was I put a metronome program into his earphones, free metronome, and we set his cadence high at like 175 to 180. Now, what that did was, first of all, it forced him to load the opposite foot, and then it forced him to regulate the load through each foot. So the force is then going to be even. Now I want him to load that pathological foot the same as the other one, because we know he's got a structural problem. I'm not going to make him any worse, but I'm going to determine whether he's healthy enough to sort of complete this bloody marathon that he wants to do, because he's going to do it anyway. So I gave him a metronome to even up his weight distribution, and it made a profound difference. When we rechecked him at sort of 7 weeks later, 50% reduction in overload. It's a win. It's a big win. From there, he can then go off and do this bloody run that he wants to do. So it's a small win. It's a small victory. Even though I don't condone people trying to kill themselves in marathons when they've got a structural deformity, this guy's going to do it anyway. So he'll run the marathon with a metronome program. He'll do everything we tell him to do right up until that run takes place, and then he's going to review with the consultant in the new year. But the Podo Smart was integral in this patient's care, not just from the gait retraining point of view, but from the psychological point of view. You could see the figures. You could see, oh shit, it's 8%, and it's an overload. And someone like that, someone who's headstrong and knows what they want and knows what they want to do, you have to show them and say, look, don't just take my word for it, because this guy's seen loads of people, not got anywhere fast. Now, that's been a sort of small success story from my side of things. In terms of using the Podo Smart for other bits and bobs, I've seen wonderful results with it. The return to fit was the big one. So we did the gait retraining, walking and running with a post-op Achilles tendon rupture. For a professional football player, soccer player. We got him back. He was already X amount of months after it, and I saw him, and then we got him back in about 3 months, and he recently played at the European Championships for his country. So the run analysis in that showed a 50% differential. 50%. It was an actual figure of 50%, not 8 and 4. It was 50%, where he just was not loading that Achilles tendon. We matched it with isokinetic testing and loads of other bits and bobs, because you imagine soccer players in this country get paid an awful lot of money. So he was a high priority, and we got him back. Rehab gait assessment, so where you can start putting things in like post-operatively. If someone's had an operation, you can do a walking analysis pre-op, 6 weeks post-op, 12 weeks post-op, and then you can use the evolution chart on the Podo Smart to start change people's parameters. And I'm going to be publishing a couple of case studies on that for Digisol. Incidentally, the soccer player with the Achilles tendon, that case study is already published on the Digisol website. Dynamic pressure and then sport and performance. So I was lucky, I worked with about 4 Olympic athletes who represented in Tokyo, and one of them was an 800 meter runner, and she ran a PB in the 800 meter Olympic final. And that was just through looking at a couple of different bits. I mean, she's the one, she's gone away and done it, she's the athlete, but I like to think that we played a part in that, and she was very grateful for all the input, and PBs speak for themselves, don't they? So that was always a positive. Again, this is just the pre and post-operative use of the Digisol, and it's something that I'm going to be publishing again. I've got a hallux rigidus going through surgery, and I've got a hip replacement going through surgery. So I've done pre-operative data collection. I'll do post-operative data collection and demonstrate a physiotherapy program as well. And then I'll publish it, and you guys can have a read of it, hopefully, and it might be useful. I don't suppose we're doing questions because I think we're doing the round the table thing. But what I have done is I've put my email address on here because the email address that I gave you guys, the website's not active yet, which is wishful thinking on my part. But that's my email address if anyone wants to get hold of me. And that's it from me.
Unmute. There we go. Sorry. Nice job. Really great. So I think the best thing for us to do since questions is we'll just move over to the round table, and then you can answer any of the questions that anybody has. I know Bob had a couple regarding footwear and modifications in terms of for various impingements and so forth. So we'll address those in the round table. Awesome job. Let's leave this room and go over to the round table, and we'll see everybody over there.